It is a little after 12, and I know it's a busy Friday, so we'll go ahead and get started. First of all, I want to say uh, yesterday we had an ABIN conference, and as part of the conference, one of our speakers, Dr. Laura Sideri, spoke on the collaborative care model, or CoCM. And so we were grateful to have her here in Arkansas and to bring that to Arkansas. Woo! So, I'm thinking in grant language, that was an opportunity really for us to bring a statewide training on CoCM. So thought that was good, and want to thank everybody who was on the call for attending yesterday. Hopefully you thought it was positive and got something out of that presentation.
Yes, and I will say, I feel like that for Arkansas, that's such a great opportunity. Our team doesn't get a lot of opportunities to travel, to go to conferences and get kind of that energizing boost that you get. And it's very expensive to, send 15 people to a conference. And so, the opportunity to have it be in the state and inexpensive slash free, and we were able to help support our team members that were in our regional programs, help support them to get here, so they got to spend the night before and come to the conference. But it was just, it was great because we don't get to do that very often. So really,
Awesome, Tisha. Wonderful. That makes us know this is why we're doing that. And that's what we hear is we have phenomenal resources in Arkansas, but sometimes when we bring in other people, especially national experts, they get to share from their perspective what they see happening and what's happening in other states. And so that's always nice to see.
She's a phenomenal presenter. I mean, to
Yes.
be, her knowledge base is clearly extensive, and she's very enthusiastic, and that's wonderful. But just because you have those things doesn't mean you're a great presenter. And it's brilliant, right? The idea of taking the personality of your children and using them as a lesson on collaborative care, and being able to share of yourself that you lost a child in front of a big audience. Unbelievable. I mean, it was just phenomenal. I wish I would have had, more people in my world go to it. It was just phenomenal.
Is that Laura Sidari?
Yes.
Yeah, it was Laura.
Yeah.
I mean, and I mean, sharing something like that loss in front of a group of people is huge. But in addition, using her children's personalities as an object lesson for all the different things that have to come together to make behavioral health integration operate. But that is just brilliant.
Yeah. She's great.
I was so impressed with her.
She did a fantastic job. And Vern, I have to tell you, you are the topic of a lot of our conversations.
Oh, no. I did talk to Lisa Horowitz. She called me and she was like, tell me a little bit what I need to present. Yeah.
And it was all wonderful things. It was all how wonderful Verna is. So we want to give you that shout out.
Thank you. Lisa probably knocked it out of the park too. She's really good too.
She is. She was phenomenal.
Yeah, she's great.
The woman from NIMH.
Yeah.
Yes.
Yeah, I would like to sit down and chat with her some more.
Well, you can actually. She's coming to speak at a conference I'm doing in DC, which is for all of the FQHC leaders and some folks, Kim, like yourself, from around the country. And so I'll send the invite and the save the date, but she's gonna come and be there.
Okay,
That would be helpful. Thank you.
we appreciate
Yeah.
that. Thank you, Verna. All right, well, welcome everyone. Any other announcements? Just wanted to put a shout out that we definitely want to make sure we're adding this into our reporting piece for our CoCM grant, because I think that was critical. Yeah. Um, Yes, thank you, Dr. Gibson. The recordings for the conference will be on the ABIN website. And so if you want to share that with your colleagues, please do so. And I don't know about you, but sometimes I like to go back and there are pieces that I heard that I sometimes need to hear 2, 3, 4 times um, because they're so powerful. So um, wanted to remind everyone of that. And then we got a couple of people who will not be able to be here today. David Jones, he is out today, so he sent an email with his regrets, and he'll catch up with us next time. However, he and Paula Stone were both at the conference all day yesterday, which was great. So they got to hear this information firsthand as well. And then Chad sent us an email and said he won't be here, nor Julie. So I know a lot of people had to travel yesterday and are headed back, but wanted to give you all that information. Okay, and then uh, so one of the things that we did, and Teresa, I'm going to lean on you because there's a lot of um, formal words that we're using, but we talked about using this statewide CoCM stakeholder meeting as the statewide CoCM grant meeting. And in doing so, we are inviting several people from the executive council for the grant to the meeting. And so not only are we inviting them, but anybody in the state who is interested in hearing about CoCM, learning more about CoCM, advocating for CoCM. We appreciate you being on the call. We do have a new face on today, and so I'm going to ask Jeremy Stark if he'd be willing to introduce himself and tell us a little bit about yourself, Jeremy, where you work, and what your interest in CoCM is.
Thank you. Thank you for inviting me. I am Jeremy Stark. I am the Behavioral Health Director at Community Clinic in Northwest Arkansas. And so I've been here since October, so fairly new, learning a lot about the integrated care models, behavioral health models that are out there. We currently do not use a collaborative care model. Here we use a primary care behavioral health model, but we are always looking to grow and expand. And so wanted to learn more about it and what that could look like here. So that's kind of why I wanted to join. And then also just I love integrated behavioral health and want to do what I can to promote it in the state of Arkansas. So that's also why I'm here.
Awesome. Welcome, Jeremy.
And while you're doing that intro, will you just say a couple lines about community clinic and what it is, how many sites for people?
Oh, yeah. So Community Clinic, we're a federally qualified health center here in Northwest Arkansas. We currently actually have 27 sites, 2 of which are in Oklahoma as of April 1. And we last year we served about with 20 clinics or 19 clinics, we were at about 45,000 patients. With the new acquisition, we're looking at closer to about 70,000, 75,000 patients projected next year. And yeah, we have a MAP program. Our primary focus is primary care, but we also have 2 dental clinics, and then women's health, and our pediatrics clinics are fairly large at this point too. 3 specific to pediatrics. So that's kind of community clinic.
That's awesome.
Awesome.
And currently, are you practicing with more of a co-located model or the PCBH model or?
Yeah, so we're using the PCBH model. So we have our behavioral health consultants are in the clinics, and then use telehealth for any of the smaller clinics. We have like 10 clinics that are school-based health centers. And so if they have somebody, they can put them up on Zoom. And so we utilize kind of warm handoffs, combination of warm handoffs and follow-up appointments, and utilizing telehealth. With these new clinics that have just come on April 1, we're actually in the process of trying to be able to integrate them in and get the electronic medical records aligned. Right now we have 2 parallel systems, and so it's been a lot of fun trying to figure out all those pieces. But yeah, so we have behavioral health consultants in our Fayetteville clinic, Springdale Clinic, Rogers Clinic, and one in Siloam Springs, which are our kind of 3 major clinics, with Springdale being our main campus. And so they're located in the clinic, and are kind of just integrated fully into the care team. I always try to describe to people that we have our primary care providers are the medical side, and then our BHCs are the behavioral health side but we're all the same coin, just 2 sides of it. So.
Hey, Jeremy, this is Mark
Yes.
Jansen of Blue Cross. I have a question for you, and I'm eating lunch, so if I'm not on camera, it's not that I'm shy. I just don't want y'all to watch me chewing. If for your school-based clinics, do y'all do behavioral health in those clinics as well?
So we will see for our behavioral health, we'll do our integrated behavioral health for any patients that are in the clinic. But we are separate entities than the schools. And so the schools a lot of time have school-based services in the schools. And so we do a lot of referrals if they're needing more of that long-term kind of school-based care. We work really closely with them to get them referred over, but our BHCs can definitely see them if they're there in the clinic and have BH needs in that moment.
Okay, that's great. Thank you.
Yeah, thank you.
So just a clarification on that, Jeremy, do you have therapists that are actually in the schools or the? Okay.
No, we work closely. So in Northwest Arkansas, there's several really large community health agencies. That's actually where I came from, was Arissa Health. And so they have a presence in pretty much every school in Northwest Arkansas. So we work really closely with them to get anyone that, if they come into our clinic, into a school-based health center and say, I would like my kid to start counseling, our behavioral health consultant can work with them in the moment, work with that family. But if they're needing or wanting that long-term, then we'll just kind of bridge over and kind of follow them until that referral kind of is in place and they're being seen at the school. But we're not actually in the schools providing therapy. We just have a pretty close relationship with Arissa. Also, there's Chenal Family Therapy up here, Eason Counseling, Springwoods actually just got into school-based. So there's several now that are doing school-based services. And so we just kind of work with those referral sources.
Yeah. Appreciate the segue because although this is a CoCM group, integrated behavioral health is, there's so many gaps in our system as a whole. And so I think all of us need to be focused on integration as a whole. And as we add specific models, whether it be CoCM or PCBH or a co-located specialty model, that we are aware and intentional about what model we're choosing based on what are the outcomes. And why would you choose to combine PCBH and CoCM? And that's one of the things that Dr. Sederi's program has done really well. And so even though this is a CoCM grant, I think we really need to keep in mind all the models. And when we work with a clinic, and I know Tish's clinics at UAMS are using PCBH, and then they have connection with the outpatient clinic. But the schools and law enforcement and all these different areas, if we can keep in mind closing the gaps, I think that we can make this grant really make a contribution overall to improving access to mental health. So I'm sorry to put you on the spot, Jeremy, but we appreciate you bringing us that perspective and your multiple experiences.
Yes, yeah, I appreciate y'all.
Jeremy, do you guys work with the University of Arkansas and Dr. Bridges to have like the interns, the psychology interns or externship?
Yes, so Dr. Bridges and I work pretty closely. She's been super helpful, just kind of meeting with her and talking about integrated care. And then I have currently one clerkship, I think is what they call them. But
Yeah.
and then come fall, we're gonna have two. And I think we've pretty consistently historically have had at least one or two for the last several years.
That's great. She was my dissertation supervisor at U of A. I love her. So, and I thought that
she's wonderful. Yeah.
Yeah. Well, and Anna and I, we started that program together.
Right. Yeah.
Yeah. A community clinic. Let me ask, how many BHCs do you have now?
I am currently have 4 right now. I've hired a 5th one that should be coming on over the summer. And then I have in total, I have 11 interns, 7 of which can see patients as like BHC interns.
Fantastic. Okay, well, welcome, Jeremy. We appreciate you being here.
Thank you.
Okay, so we will not be getting an update from the state today because David Jones is out, but want to give an opportunity for UAMS to give an update, anything going on, and then we are going to move to talking about the registry.
Hey, thank you. It's actually been a really busy month here. We finally got our jobs posted for our behavioral health care managers, and we have 4 viable candidates, and so we're just in the process of contacting them and getting interviews set up, and so I'm very excited about that. We've actually got some really neat people, and I like that we've expanded and are not just looking at licensed social workers or counselors, and we've got some neat candidates who have bachelor's degrees but have like great interest in medical support for patients, and also have really neat experiences in kind of building different programs, and so I'm really excited to talk with them. So that's been like this week development. We also, as I think I've said before, we've had a project approved since December to work on building registry in Epic for us, and that project is now slated to be getting started this week / early next week. I've got a meeting to really look at the scope of that on Monday, and talked with one of our the psychiatrist that works with us / she's one of our IT fellows about some of the options. I actually just talked to him at 11 o'clock today. So that is a process that's getting started, and we're going to have a group and a team working on that. We've also made some progress in being able to track our minutes and look at billing in the next couple of months. So I think we've made some real progress. I feel like in the next couple of months, we'll probably have at least one, maybe two behavioral health care managers on board. And we have implemented in or kicked off in Pine Bluff, and that is going well. Slow start always. We've got about 5 patients today, and looking at ways to expand that. I guess the last thing, as part of the end of the last Blue and You grant that I got, we actually brought in Dr. Anna Ratzliff and Monica Harrison as consultants to do some site visits for us last week. So they came in from Connecticut and the University of Washington, and they had a meeting with Dr. Dunn and Dr. Cargill of PRI. And they also met with with Sandra Meredith Neve, who's the nursing director, to talk about, kind of high level things that we need at UAMS to make this work. They also did walkthroughs at 3 of our clinics, internal medicine, at Batesville and in Pine Bluff, and kind of walk through the whole process of checking in and our consent process, and talk to all of our stakeholders. And I'm looking forward to kind of hearing kind of their written feedback, the official feedback, but we also, got to have some good conversations with them and get some good, ideas from, people who are not mired in the day-to-day stressors. So I think that is going to really help catapult us getting their feedback and recommendations for what we need to be doing going forward.
Can I ask you, Tisha, are you going to do episodes in Epic?
Yes.
So you're going to have a collaborative care episode?
Yes, we already have a collaborative care episode. We had that built a long time ago.
Oh, nice.
More about
Okay.
now us getting it, using it consistently.
And then mapping it to a dashboard. So you'll have dashboards too, right? Oh, awesome. Yeah, that'll be fun. Nice.
Yeah.
Very cool.
Tisha,
I'm
congratulations.
excited.
What an exciting update.
Like I said, it's been a lot in a very short period of time. So
Yeah.
hanging
Well,
on.
hanging on. And how awesome that they were able to be there last week and do a site visit and give you all some feedback.
Yeah, they were really great.
Wonderful. Well, it sounds like that piece of this grant is moving right along.
One other thing to pass along that I
Oh
thought.
yeah, Michael was at the meeting too. Sorry. Left Michael out.
One other thing that they were very impressed with was the state's effort in collaboration, and the fact that this group was getting together on such a regular basis. It was something that they had heard about and seen, and others had tried to do, but to have a group together for as long as this group has been together to consistently meet and work and collaborate rather than fight. They were very impressed with it. I just wanted to pass that along as well. So, and I'm going to join Dr. Jansen and chew offline, but I'm here.
Thank you, Michael. Well, yeah, Arkansas We are very fortunate, and we hear that. I've been hearing that quite often, especially as we're talking to other states and partners that we work with in other areas, that we're fortunate in Arkansas that we have a team that comes together and from all across the state, all different sectors, and we're really interested and passionate about how do we get this sustainable in Arkansas, right? And then we bring in these outside experts that are now our friends, like Verna, who consistently comes and joins us, and Nicole, and provides us information on what they're seeing, and helps us see, well, this is what might be happening in New York, or this might be happening in Washington, or whatever it is. So that's awesome that was some of their feedback. That brings us to, one of the things that we have on our registry today is to talk, or on our agenda today, excuse me, is to talk about the registry, because the registry is something that is really important to this project. It's important for all of the clinics that are participating, that they have access to a registry. It's exciting, UAMS. It sounds like your registry will be up and operational very soon in Epic. The two different FQHCs participating in this project reached out, and their hope was to embed the Ames registry within their EHR. And reaching out to Ames, I found out they're no longer doing that. And I see Verna shaking your head. Yeah, I've been
Yeah,
emailing Diane back and forth.
they will customize it though. So like they do for New York or North Carolina, they will do like one version that the project could use, right? So that they could actually share it, have different logons. The good thing is you could get data, and all the data would be in one place, and then you could support the costs in the grant or share the cost, across the FQHCs, however you decide to do it. They do that. Although you don't get they have some interoperability, or you could do like Mira could do it if you wanted, and Mira could put a registry and that would interface with the EMRs perhaps, and then you could customize it. So you've got some options.
We're waiting. The last I heard from Diane is she is finding a partner that could do a demonstration for us on potentially some of the data that on how they're using, how an FQHC that they're supporting is using their registry. And because one of the concerns was duplication of entry, they didn't want to have double entry.
Yeah, I can get you plenty of FQHCs because there's a bunch that use it in New York and a couple of other places. I think it's less about it being an FQHC and more about what you decide to put in the registry. And so like in New York where they have the CMTS, it depends on their EMR functionality. So like some of them use it for time if they have to, others don't. And so it varies a little bit based on whatever functionality they have, but they don't document. They just put the PHQ score, they put active patients in there. If they need to track the time and the EMR doesn't do it, they put it there. So it's very limited documentation unless there's a couple of things they need to be able to do for billing. But I can actually let you know what they do.
That would be great. We've also talked with Dr. Sideri, and she's working on this same CoCM grant in New York State.
Yeah.
And gave us some ideas about things we could potentially, we could maybe do a hybrid, some things we might be able to program into their EHR, and then
that CoCM grant is the PEDS one. So let me know, and I'm glad to connect you or answer any of the questions. We have this conversation often with organizations or with groups or states about what registry to use and how to advise them to use it. Like, unfortunately, in New York, every place in that project has a different EMR. And so some of them are using CMTS, some of them are not, based on functionality. And then across New York, what New York did was they supported for the first year, and then after that, organizations split the cost across the organizations. Right now, there's another state that's writing this grant. They're thinking about using CMTS because they like the fact that they can pull the data from the back end.
That's
But
what
there isn't going to be required field. So, but either CMTS or Mira could do that. That's not a thing. It's just a matter of if you want to customize it at all, like for different diagnoses or something like that. But yeah.
No, that's really helpful. Thank you. Both of these FQHCs, I think, are using eClinical Works.
So for ECW, there is functionality now in the care management platform where they can track the time, and generally they track their patient caseload on the tea jelly beans, and they use the tea jelly beans and keep them open for the month. If they're already doing chronic care management, then they might want to use the CMTS or the registry for the time, because it's very hard in the ECW care management platform if they're doing both to distinguish them. So that would be a very strong key question for them. Are they currently doing chronic care management? If yes, then they likely will use the registry for time, because they likely don't have the functionality to track the time another way.
Okay.
But I have someone on my team that's actually an expert in CoCM and ECW. So if you want to connect at any point, then let me know, and I could certainly, and she also is very familiar with CMTS, so could be helpful if you need.
Perfect. Thank you, Verna. That's why we're so grateful. We bring these questions to this group, and we're getting our answers, our solutions. So awesome. I just have to say, for our newcomer, Jeremy, you didn't know that would happen so quick, huh, Jeremy? And I have to say, we've talked in in circles sometimes. I have for years, and this group, we bring in questions, and we have people from all different backgrounds and different expertise and different settings, and they're bringing their knowledge, and they're so gracious with sharing. Thank you, Verna.
Verna, thank you.
Verna's hopping off.
Yeah, and I just wanted to add, I put it in the chat, but we use the CMDS right now, and we've been using it for over a year now. So if they want me to demonstrate to them or show them what it does and how we use it, it's really not bad at all. For me, it's just we're gonna have 15 clinics, and to have that many, it's going to cost quite a bit anyway, and there's the ability to actually to be able to use our medical records. So I feel like that's in long term the best option for UAMS, but it's a perfectly usable platform.
Yeah, well, and I love that idea, Tisha. I also love that Verna said, even though we may not be able to, AIMS may no longer be embedding this, they might be, and this is what Dr. Sideri also said, they might be able to make customizable pieces so that the double entry is really limited, because I think that's their major concern. And so making sure we're working on that, and Diane is helping us out, helping us trying to figure out that piece. So as soon as we can get that piece figured out, that will be great. Just to keep you all updated, a couple things we are doing. We have developed an organizational assessment for each of the FQHC systems. We'll be meeting with them and going over those assessments. And then we'll be starting our first training for them. We'll do a 3-hour training in May, and we'll let you know when we get a specific date. Verna will be doing that training just to talk about nuts and bolts, basics of CoCM, looking at how that goes. Our plan is we need to do these 3 trainings by the end of this first grant year. So we'll do one in May. Hopefully May, June, July. We got a little bit of wiggle room. I'm going to be out a bit in September, so I want to make sure that we're getting it done prior to that time. Um, that's our update on that. Anybody else have questions or thoughts on registry pieces, or I don't know if anyone's here on the call who wants to share, in addition to Tisha, what registry they're using, how it's working in their EMR.
I'm going to make a shameless plug. For those of you who are CFHA members, and maybe for those who are not, we can get you on. But in May, the Collaborative Care SIG meeting is going to be a group of different registries, people who are doing registries to talk about their registry. Berna will be one of the speakers, kind of talking about what they do at, oh man, okay, what is Concert Health. I was like, Berna's gonna kill me. At Concert, we're gonna have, is it VJ? Who has the free registry. He's going to be talking about his. I think we've got, I can't remember now. Anyway, I will send out the information, but we have like 4 different people who are going to be talking about their registries, kind of pros and cons of like, contracting versus, kind of having your own versus different things. So that's going to be, I think, a great resource for a lot of people.
Awesome. Thank you, Tisha. Yeah, that will definitely be helpful. And to give a shout out, there is someone, VJ, who is on the CFHA, and he is diligently working on trying to come up with a tool that is free, that encompasses all these different pieces that he sees. And I've noticed he's new to this, but he has the programming and coding expertise, and he has just been really a champion for trying to get something free. So that's really exciting. I can't wait to hear what he shares. Okay. So just so you know, we are working on that registry piece. And that hopefully that will happen quickly. Diane's been fantastic at Ames, and she's been coordinating with me on different pieces that might be needed for them. I also want to give a shout out. I heard yesterday on one of the talks when Dr. Sajeri was talking about CoCM and the sustainability piece. She talked about the importance of Medicaid turning on codes for payment for CoCM codes. And they did that a few years back. And so that's been critical to the sustainability of CoCM and this project for them. So I thought that was good for us to hear, that people are hearing it from other states, other speakers, not just us local folks.
Could I offer a comment about that, or maybe a question?
Sure.
So I met with Paula sometime in the last couple of weeks, and one of the big things that she asked me for from this grant that she didn't really ask me for before we wrote it was, I would like to know what kind of education information that people would need to use codes if we turned them on. And so I really need some help. No, I think we need to really give that some attention, and then to present her with a sort of an assessment of what is unknown about the codes, perhaps, but more importantly, what kind of education exactly do we want? Do people need to demonstrate it? Do we need some kind of, I don't want to ask for a great big government document, because those can be a challenge, but what would we need? And so, or what would and I'm using we to mean Arkansas primary care that would want to bill these services to Medicaid. And it seems like this is the group that could help me fashion that information, and we could as a group present it to her.
And I mean, I wonder from her, like, what does she, I mean, education, like, what happens is people create codes and says this is the requirements, and people have to meet the requirements. I mean, like, that's what happens with every other code.
Are you meaning education specifically on the billing and coding piece, or education on what they might need as a foundation of what this model is that would then build upon what could we bill for these specific services?
So I probably should go get clarification, but the way she said it, it seemed like she wanted to know more about, if she turned codes on, what does she need to tell people to make sure they use it well? And I think maybe some of that is Medicaid sometimes denies things. And I think she didn't, not I think, her idea was to avoid putting some codes out and then suddenly be denying them. She didn't want to do that. And so I took it to mean primarily putting codes out and making sure people knew how to use whatever codes were turned on. And
Yes.
how do you put a comment? Go ahead.
I was going to say, I definitely agree. And I hear that. I think that we have to layer a little bit of an infrastructure on education, what this means, what are the BHCMs doing, what are the psychiatrists doing. And I'm going to defer to Dr. Gibson, because we know that there's already different training pieces built. And you could speak to this better than probably anybody on the call. I don't know if you want to share any of your thoughts.
Teresa, I think that is a great conversation that you've had, and that this group actually could create some, an easy guide for Paula and her team that are trying to make the decision. And so they have isolated the two things, like information about the codes and what are the different elements, because you're hearing them talk about registries for several meetings now, and that is essential. And I think Paula's afraid people are going to kind of get off track of the model and say that they're doing it when they are not, and there's very specific things that are needed. So the CMS has a guide. We could come up with a guide that then Arkansas Medicaid could publish in their requirements. But the other piece that Kim is alluding to is that, and Tisha as well, is that how to do the model. I think Paula really wants to make sure that if we're going to implement this, how to do the model. And fortunately, that's what we're doing with this grant. And so you're getting the deliverable that you're overseeing with the ABIN CoCM page and the trainings. And so there's that initial, and then providing ongoing technical assistance as people start to do it, and then it's harder to do than they think.
I agree. I absolutely agree. And I'm really grateful for you all, to help me think this through and to come up with the right thing. One thing that to me seems to be a challenge of turning on codes and using them correctly is there are different models. And so are there certain codes that will be for only certain models? Or if you check off certain boxes, you can use the code regardless of which model you use. I don't, and she's,
Perfect. That's a great question, Teresa. That is a great question because, and Dr. Sederi, when she was talking yesterday, she's used the word collaborative. And over, I hear people saying, yeah, we're doing collaborative care. And they meet the word, it's kind of like saying integrated care. But there is a very specific CoCM code, and that's why very specific model. So Jeremy said he's doing PCBH. He's got the therapist there, but the CoCM codes are very descriptive and prescriptive, and so they need to, Medicaid needs to understand that, and people that are doing it, so that they don't just say, yeah, we're collaborating, and they're talking to each other, and they're not including a psychiatrist that has to review the panel. They're not having a behavioral health consultant. It's like you heard Tisha say, well, we're looking at not using licensed providers as our behavioral health case managers because that is allowable in the codes. The other thing I think that we need to give feedback to Medicaid is share lessons learned in other states who have just turned on the codes. And what frequently happens is Medicaids in states will say, okay, we're going to turn on code XYZ and we're going to pay 75% of CMS. And North Carolina has already even published a study in JAMA saying that North Carolina had to increase the reimbursement rates to 140% of CMS. Because if the to do this model, it takes money to get it started and then to continue it. So the reimbursement is critical. So just turning them on is not going to do enough. They need to be sure they reimburse it enough to make it worthwhile and to make sure people do it appropriately. Because if they don't reimburse enough, people are going to just say, yeah, we're collaborating and send that code on up. So I think we can get some of this for them.
so I appreciate you saying that, because what I think we can do, or what I think would be acceptable, is for us to create documents, slides, whatever, that really identifies aspects of turning on codes that need to be addressed, right? So go ahead.
No, I was just going to say, Patty had mentioned, and I put in the chat the CMS document, and it's very specific and describes very well the codes and how you have to use them. So I think modeling something after that.
Absolutely. Or just using that because CMS is the.
Well, I think they've been given it many times, so I don't like.
But I think what she's maybe asking, and maybe any of you can speak government better than I can, but I think she's asking how we roll these codes out. What do we need to first educate people about what models are going to be considered acceptable, or which codes can only be used for which model, because buried in a big document, they may miss them. And so I think she's actually saying, what do you recommend to roll these codes out? I don't think she wants to put out, a email that says, I've turned on XYZ codes and refer to this document to use them. I think she really wants a rollout plan, an implementation plan. And it seems like you guys are the experts that can. I'll be happy to write, but I'll be needing some expertise to help me do that.
and when I hear implementation plan, to me, that makes much more sense because as Tisha said, CMS has a wonderful, beautifully laid out step by step. Here's each code. Here's what you could bill for. Here's how often. And I know Verna is off, but on a lot of the CFHA calls, and Verna speaks to this as well as Dr. Gibson. When codes are turned on and there's not preparation, there is slow uptick, and we're not seeing states practices have a large amount of people do this because there's confusion on, well, what is this? What would I be doing? If I build this code, what kind of service would I be providing? How often could I be providing that service? And so I think there's a lot of confusion, and I'll just say I think that some type of education piece is critical. We know that the APA, they have a beautiful training that's on their website, and you can go on there. I've gone on, I've listened to their different modules, but laying that foundation, in that implementation plan, we have to have a foundation, we have to have the education and the codes. This is just my opinion, but y'all please join in. But we can't just say, here's codes, build them, because we don't know what to do. It's like a new car. I always laugh. I say, if people give me, brand new Tesla and I'm using a key and still have roll down windows, well, gosh, this is really nice, but how do I turn this car on? I can't even get to the grocery store.
Exactly.
No, and I mean, I totally agree with the conversation that I feel like that they're trying to be really thoughtful and deliberate and want this to be successful. And, a little bit of what I worry about is sort of a chicken and egg kind of place where we get to, where it's like we have to have everything be perfect before we turn the codes on, but people can't implement without a pathway to get paid. And so it's, I feel like that if the codes, we wait and the codes never, I'm not going to say never, they don't get turned on, then, and there's not a definite time and when it's going to get turned on, then, there's a lot of chances that it just won't get used. Does that make sense? Like, I feel like that we're trying to grow and roll things out, and if there's not kind of an idea of when this is going to happen, educating people for 6 months about something that might happen is kind of a difficulty.
And I might be a little bit self-serving, but frankly, by the end of year one of this grant, so September 30th, well, September 29th, we must submit a sustainability plan from the grant. And I think this would be an ideal time to say, this is our timeline, and this is for fully implementing this, including, I don't know how to say this politically correct, please forgive me. It seems like Medicaid is sort of the last holdout to billing. And holdout's probably not the right word, and please don't make Paul upset with me.
How about you can say adopter?
Thank you.
Politically correct.
Well,
and yeah, and that is, correct in that the law was passed, which kind of made everybody have to do it, except for Medicaid. So,
right.
And the last adopter.
And I, maybe that was the right thing, maybe not, but in any case, we are where we are. But we have this opportunity by the end of this year. We have to create the sustainability plan and turn it in. And it would be the ideal time to say, what does the implementation plan for the state look like? And put a heavy emphasis on Medicaid because that's our last adopter. And by then, you know, Blue Cross, of course, is aren't you the biggest private healthcare insurer in Arkansas? So you will have both lessons learned and issues that you still think need to be addressed or plans for addressing it or whatever. So you may have some private insurance, if that's the right word, to add to this plan so that we're very clear that we're addressing the whole state. I think that's an important part of this grant, is to address the whole state. And then since we have one late adopter, we need to address what's going on with that late adopter.
Well, in a way, is the state, since the grant money is coming to the state needs to say what their sustainability plan is. And
Well,
Tika is making a fantastic point that the implementation, and UAMS is a perfect example. They've been working on this for years, and we have clinics. I see Nicole Portrude is on from Mindula, and one of the barriers, slowness for implementation, is because clinics have, you know, payer mix that includes Medicaid, and you can't break even if they aren't going to pay. So,
well, it seems like this is an opportunity to make a plan. My thought was to write the plan with not in isolation, but with all of you, and then engage with Paula and David about what do you see in this plan that you think is confusing, problematic, whatever, so that we get buy-in from the state with a final document that makes SAMHSA happy, that's acceptable to the state, that has the key things that this group views as essential. At least.
Yeah. And the AIM Center has some nice like modeling spreadsheets. I've used a little bit trying to kind of figure out financially like what we need to bill and what our payer mix is and all that kinds of stuff.
And implementation plans.
Yeah.
But so I have looked at those, but I maybe I had a different hat on. I was viewing them as if I were a clinic, right? I was leading a clinic and I needed to implement. I'm not sure that I've looked at them thinking about what if I wanted to make this the norm across the entire state? What would that implementation look like? But in any case, and that's probably my weakness there, but I would really be grateful if y'all could start thinking about what a sustainability plan would look like. And I think of it more as, so the way they wrote this, the way the RFA is written, it's if you were going to take a couple of clinics and put this to them, and then how are you going to sustain it? Or maybe you're going to do it with all your clinics, but how are you going to sustain it going forward? And I would like us to make sure we consider the implementation. So begin at the beginning, I guess that's what I'm trying to say. We have, the codes aren't turned on. The clinics can't charge Medicaid. So how can we start there and take it forward? And I think we could make a nice document that does that.
I'm so glad you're willing to write, because I'm just not a writer. So,
Well, see, that's why it's team sport,
yeah.
right? You guys are all really smart and I can write. So that's why it's a team sport.
And maybe pulling looking at what other implementation plans are out there in addition to AIMS could be possible.
Yeah, I mean, that's the thing. Maybe I can I'll put it on my to-do list. Like I said, I have never thought about implementing a practice across an entire state with all the different kinds of clinics and things there are. So I will have to, I'll do a little homework on that. And then maybe I'll get Tisha to the side and see if she likes my homework, have her grade my homework.
There
Yeah.
you go.
Well, I think, North Carolina and New York are both
Oh, yeah.
states that kind of did this in a statewide way. I think the hard thing is that a lot of times when you bring things like that to Arkansas, they say, well, that's not Arkansas. So,
Well,
they're good models or models to think about how we can adapt this.
And
right. That's the beauty of it. We can change it around and make it our implementation plan.
Yeah.
we have met with the North Carolina Medicaid team, their medical director, talked to them, looked at some of their implementation pieces. And they talked about their barriers. They rolled this out over their AHEX, but it was a long game. It wasn't just, we're going to do this in 3 months or we're going to do this in 6 months. And so I think that's something for us to be aware of as we've met with them. The positive is we get to hear from them and get to hear some of the challenges that they faced. And then maybe strategically think about how are we going to develop a plan so we're not having these same barriers. But when we saw yesterday the slide with the different pieces, some are triangles, some are octagons, some are circles, some are squares. How are we going to be putting all of these pieces together and hoping that's going to be our challenge, I think.
Teresa, if I could give you some guidance, just because I've been out in the provider community for a long, long time, running my own practice, being corporately owned, working in an academic medical center. The problem you're going to have in Arkansas is the landscape is so heterogeneous as far as the providers that are out there. Some are doing wonderful longitudinal care. Others are purely into episodic care. You have senior physicians who've not seen a CME conference in years who are still practicing something that's 10 or 12 years old, if not older. So it's going to be really hard to get anything adopted across the state. Your best effort's going to be to find hopefully a large vertically integrated healthcare delivery system that has the opportunity to influence what goes on in a primary care clinic. You're going to have to show the evidence behind it. Of course, they all want to see an ROI, but sometimes the ROI should be zero if it's the best thing for the patient. There's evidence that it is beneficial, because not everything has to make money. You just can't lose money. But if you can show it's neutral, because the bean counter is going to be all over you if you're giving things away that cost the clinic money and take resources away from others. Then once you establish best practice with a willing, sophisticated partner, that's when you then go back out and proselytize what you've done with this one clinic and create a competitive environment so that others want to join because of how successful it's been. And like Kim said, that's a long game. That's not a short game.
Well,
I mean, they can't agree as to what toilet paper they would want to use, much less what would be best practices.
And thank you for that. And I did have some of that thinking in mind when I wrote this. And if, in retrospect, I might have written it differently if I was going to write it tomorrow. But I had a short time, and my thought was if I could get UAMS fully fluffed out so that it was doing it completely, and it had different clinics serving different kinds of populations, and then the couple of FQHCs that have models that are not exactly a CoCM model, and we could work with them to change it, we would perhaps be able to influence a lot of sectors that way. That was my thinking, and I may not have quite hit the nail on the head. The good news, though, is I think that we are, I don't think we have to keep doing the same thing every year exactly as I said it in the proposal. I think as long as they're pleased with the plans we submit and the reports we submit and the way we use our funds, they'll be open to us saying, hey, we need to do it this way and this year for these reasons.
Your best contact on the regional program side would be Shashank Kraletti.
Oh,
If you know
yes.
Dr. Kraletti, and then
Oh, yes.
if you were going to chase down an FQHC, the largest one that has a lot of imagination would probably be R-Care.
Well, so I promptly involved Dr. Craletti as soon as this announcement came out. And to give you all a little background, I just assumed that Dr. Craletti or someone else would write the grant, not me.
Yeah.
And Dr. Smith was chair at the time of the, Dean of the College of Medicine. And Dr. Smith hired me at UAMS. And so Dr. Smith sent me an email that said, you're going to need to write this. And I said, well, I thought others were going to do this in primary care, et cetera. And he said, no, you will. He said, give me a minute.
I know Dr. Smith, he can be very persuasive.
Yes.
Hey, Jeremy, you said you were with an FQHC up in Northwest Arkansas. Is that all part of Danita White's program? I think she's Central Arkansas. Are you part of a larger organization, or are you to yourselves?
So we are our own organization at Community Clinic. But Judd Symingson is our CEO, and he is over the collaborative. Basically, it's the other FQHCs in the state.
So
There's
Boston Mountain and all those other.
Yeah, I think everyone except for R-Care is the only one as
Right,
far as
right.
I'm aware. Yeah.
And if you've got somebody like Jeremy who can advocate, and what'd you say, 29 clinics I heard 29 getting ready for 32, something like that.
We're at 27 right now.
27.
Yeah.
But those ones you're adding in Oklahoma added another, you went from 40,000 to 70,000 visits, if I'm remembering your numbers. So that's a big jump for the Oklahoma. So Teresa, if you're looking for an FQHC, at least on my squares, he's right in the middle of mine. That might be where you look.
Okay.
He may be sorry he joined the call. Hey guys, I got to get off and get on something else. Thank you. Appreciate it.
Thank you, Dr. Jansen.
Bye-bye.
Bye. All right. I know we're at time.
Yeah,
This is great updates today. And we'll keep working on this. We'll be back in a month and keep everyone updated. And Teresa, if I will see you in between, and this group will support our efforts as we can. Will keep us posted and let us know what we need to do.
Thank you so much. Really nice to meet all of you.
Thank you all. Have a wonderful
See ya.